All right, welcome everybody. Welcome to Endoscopy Now, tonight's virtual education event, establishing individual patient risk for progression to esophageal cancer. I'm Sri Komanduri. I'm your moderator for today. I'm Associate Chief of the Division of Gastroenterology at Northwestern University and the Director of Endoscopy. I'll be your moderator, and we will hopefully have a great and robust discussion after we have our two fantastic speakers tonight. With that said, it gives me great pleasure to introduce two fantastic colleagues tonight. First of all, I'd like to welcome Rhonda Souza as a co-director at Baylor Scott and White Health Center for Esophageal Diseases and Center for Esophageal Research. She also serves as an adjunct professor of medicine at Texas A&M College of Medicine in Dallas. Dr. Souza's interests and her expertise in molecular mechanisms and progression of Barrett's go without saying. She's extensively published in this area with a focus on biomarkers and predicting cancer progression. Our second speaker tonight will be Vani Konda, who is also at Baylor, and she's in the Center for Esophageal, she's the medical director, for the Center for Esophageal Diseases and GI Physiology Lab. And she also serves as an adjunct associate professor of medicine at Texas A&M College of Medicine in Dallas. Her clinical research and expertise include many areas within Barrett's esophagus, advanced imaging, novel screening and surveillance, and risk stratification strategies. She's also an expert at endoscopic therapy in Barrett's esophagus as well. I could go on for hours about them. They're amazing people and amazing speakers. I hope you'll enjoy them tonight. Let's go ahead without further ado and get started. And I'd like to introduce our first speaker, Rhonda Souza. Thanks, Rhonda.
Thanks, Sharif, for the invitation to join you guys tonight. I'm going to share my screen and put us in presentation mode. There we go. Great. Thank you again. Okay, so the incidence of esophageal adenocarcinoma in this country has been rising dramatically for decades, and it's expected to keep on rising for some time. This study used 3 independent computer models, one developed by the University of Washington and Erasmus University, one from the Fred Hutchinson Cancer Research Center, and one from the Mass General. These 3 models were calibrated to US SEER9 data on the incidence of esophageal adenocarcinoma between 1975 and 2010. And these models were used to predict the incidence of esophageal adenocarcinoma over the next 15 years. On these graphs, the jagged black line represents the SEER9 data, and the colored lines represent the projected incidence of esophageal adenocarcinoma for each of the 3 models. And you can see since 1975, the incidence of esophageal adenocarcinoma has increased more than 6-fold in men and more than 4-fold in women. And all 3 of these models project that this increase will continue at least through the year 2030. As you know, our current biomarker of cancer progression in Barrett's esophagus is the finding of dysplasia. But dysplasia is an imperfect predictor of cancer risk for a number of reasons. Some of the problems with using dysplasia as a biomarker of malignancy are biopsy sampling error, poor inter-observer agreement among pathologists in the grading of dysplasia, and that dysplasia itself is an imperfect predictor of cancer incidence. For example, in patients with high-grade dysplasia, only 30 to 40% will develop a cancer within 5 years. The rationale for using dysplasia as a biomarker is the belief that esophageal adenocarcinomas develop through the traditional model of carcinogenesis in Barrett's esophagus, which holds that cancers develop gradually by accumulating genetic mutations that promote cell growth. For example, we thought that the process started with the progressive loss of tumor suppressor genes like CDKN2 or P16, SMAD4, and P53. The resulting growth advantages initially cause histologic changes recognizable as dysplasia. And when you've lost enough tumor suppressors, you develop genomic instability with oncogene amplification, and now carcinogenesis can proceed more quickly, and you end up with an invasive tumor. More recent studies using paired exome analyses of Barrett's and cancer tissue suggest that only about 40% of Barrett's cancers develop through this traditional pathway. Instead, most Barrett's cancers develop through a genome doubled pathway in which p53 mutations occur early, with expansion of a p53 mutant clone that undergoes whole genomic doubling, making a tetraploid cell. This cell can now develop lots more mutations and genomic instability very quickly. And the importance of this genome double pathway for clinicians is that it can result in the rapid development of cancer and not the gradual development that is predicted by the traditional model. Whole genomic doubling could explain the failure of endoscopic surveillance to prevent cancer, since this pathway might result in dysplasia progressing rapidly to invasive cancer in the 3 to 5 year interval between scheduled endoscopic surveillances. So our traditional reliance on dysplasia to guide management of Barrett's esophagus is a critical barrier to progress in the field. Because the molecular changes that allow a cell to progress to dysplasia and cancer occur before the histologic detection of dysplasia, molecular biomarkers could help detect those patients that are destined for neoplastic progression. And an ideal biomarker would identify the minority of patients at risk for neoplastic progression for intervention, while also identifying the vast majority of patients at low risk for neoplastic progression who could avoid or prolong surveillance intervals between endoscopic surveillance. And there have been many studies over the years trying to identify this elusive biomarker, but most of these are one-hit wonders, meaning single publications with no subsequent validation. TissueCypher is perhaps the best studied of the risk progression Barrett's biomarkers and uses a systems biology approach for biomarker identification, which views the tissue as a system made up of multiple compartments that can be analyzed for genetic, immunologic, vascular, and morphologic features of neoplastic progression. The TissueCypher biomarker panel shown here is performed on formalin-fixed, paraffin-embedded Barrett's biopsy specimens and analyzes a variety of features, including well-known epithelial cell abnormalities like p53 alterations, but also markers of angiogenesis and immune cells that might contribute to carcinogenesis in Barrett's esophagus. The process starts with multiplexed immunofluorescence labeling for 9 protein-based biomarkers, followed by whole slide fluorescence scanning. The image analysis platform integrates the 15 best performing quantitative measurements of the biomarkers, serving to eliminate any subjectivity in their scoring, along with nuclear morphology, to provide an overall risk score ranging from 0 to 10 that categorizes each patient into low, intermediate, or high risk for progression. To date, there have been 5 independent studies using this locked biomarker test that have included 239 progressors and 656 non-progressors at medical centers in the United States and Europe. These studies have documented that the test can predict neoplastic progression from no dysplasia to low-grade dysplasia, high-grade dysplasia, and cancer, and that it can also predict the presence of prevalent neoplasia. And look at these data from a pooled analysis of all 5 published clinical studies evaluating the predictive performance of TissueCypher, kindly provided to me by Dr. Rebecca Critchley-Thorne, who's the Chief Scientific Officer for Cernostics. This pooled data set consists of 699 Barrett's patients and contained 152 patients who progressed to high-grade dysplasia or cancer, 38 who had prevalent high-grade dysplasia or cancer, and 509 patients who did not progress. Here you can see that the diagnosis of low-grade dysplasia from a mixture of expert GI pathologists and general pathologists did not do very well as a predictor of cancer progression. If we now just look at low-grade dysplasia that was diagnosed by expert GI pathologists, you can see that their finding of low-grade was better at predicting cancer progression with a hazard ratio of 3.9 and was also able to identify 27.2% of the patients who went on to develop high-grade dysplasia or cancer. Moreover, an expert GI pathologist diagnosis of non-dysplastic Barrett's had a negative predictive value for progression over a 5-year period of 96%. If we now look at the TissueCypher risk classifier, you can see that the high risk group had a hazard ratio of 7.7, and the intermediate group had a hazard ratio of 2.8, both of which were significant predictors for progression. The combination of these risk groups identified 61.9% of the patients who went on to develop high-grade dysplasia or cancer. And the low risk group had a negative predictive value for progression over a 5-year period of 97.5%. TissueCypher outperformed the expert GI pathologist diagnosis mostly because it detected more non-dysplastic Barrett's patients who went on to develop high-grade dysplasia or cancer. An independent pooled analysis of data on TissueCypher was presented by Prasad Iyer at DDW 2021. In this study, data from 475 Barrett's patients with non-dysplastic, low-grade, and indefinite were pooled from 4 independent case control studies done in the US and Europe. Essentially, these are the same patients that we just talked about, minus those that had prevalent high-grade dysplasia or cancer. The 152 cases were patients who developed high-grade dysplasia or cancer on follow-up at least 1 year later, and the 323 controls were similar patients who did not develop high-grade dysplasia or cancer on follow-up and were also age and sex matched. He also used a clinical prediction model, which included age, sex, histologic diagnosis, Barrett segment length, and the presence of a hiatal hernia. And the authors found that the high-risk TissueCypher score had a sensitivity of 38.6%, specificity of 93.8%, and independently predicted an 8-fold increase in neoplastic progression, and that adding the TissueCypher risk score significantly improved the predictive value of the clinical model. Thus, overall, TissueCypher demonstrates characteristics that are desirable in a risk stratification biomarker for patients with Barrett's esophagus. And I'll turn the program over now to my colleague, Dr. Konda, who will talk to us a little bit more about how to use this panel in your practice. Vani, all yours.
Thank you, Rhonda, for that excellent review. And thank you, Sri and EndoscopyNow for inviting us to participate in the program tonight. Let me share my screen. Okay. Go. So as we know, patients who present with esophageal cancer with symptoms often have dysphagia, weight loss, or other symptoms. But these symptoms come when the disease is at advanced stages, which unfortunately carries a poor prognosis. On the other hand, early stage disease carries a much better prognosis. Fortunately, we have a precursor lesion, Barrett's esophagus, which, as we know, is the replacement of esophageal squamous lining by specialized intestinal mucosa. Barrett's is a complication of chronic reflux and is a known risk factor for esophageal adenocarcinoma. While most patients who have Barrett's esophagus will never get esophageal cancer, a subset of patients will undergo a neoplastic transformation with low-grade dysplasia and high-grade dysplasia. As we mentioned, high-grade dysplasia is the best marker that we have to identify who's going to go on to develop esophageal cancer. Those patients with high-grade dysplasia without prevalent cancer have a risk of progression on the order of 6 to 12% per person per year. In addition to the risk of progression to cancer, there is a risk of prevalent occult cancer. Based on the surgical specimens from esophagectomy specimens performed for the prophylactic management of patients with high-grade dysplasia, which was done before endotherapy was standard, the risk of prevalent cancer was estimated to be approximately 40% among those patients with high-grade dysplasia, further supporting that aggressive approach. However, when we further differentiate the types of cancer, many of these were intramucosal carcinoma, which carries a small but minimal risk of lymph node metastasis and also supports an organ-sparing approach where we can try to not perform an esophagectomy, which carries a small but present risk of mortality, even among expert centers. On the other hand, invasive cancer carries a much higher risk of lymph node metastasis on the order of 20% or greater, supporting the strategy of surgery and/or systemic therapy. We also know that the risk of prevalent cancer is much higher in the presence of visible lesions, with excavated or protruding lesions carrying a higher risk of invasive cancer. Therefore, all visible lesions should be addressed with endoscopic resection for a more accurate diagnosis. EMR can change the diagnosis in up to a half of cases compared to diagnoses with forceps biopsies alone. And there is a higher inter-observer agreement among pathologists with endoscopic mucosal resection compared with biopsies. This makes sense as endoscopic mucosal resection specimens are large and intact and have good orientation. Compare that with biopsy specimens, which are small, have crush artifact, and have poor orientation. These risks of progression to cancer, prevalent cancer, and risk of lymph node metastasis support our current management strategies and guidelines. Those patients with invasive cancer should undergo surgery or systemic therapy. Those patients with high-grade dysplasia or intramucosal cancer should undergo endoscopic eradication therapy. First with endoscopic resection of any visible lesion to confirm the diagnosis, and the remainder of the epithelium of the Barrett's esophagus can be addressed with ablation. I encourage my patients on accepting the idea of an endoscopic eradication therapy program that requires multiple modalities over multiple sessions rather than thinking about it as a one and done procedure. And I will use the appropriate technique or tool based on what is found, whether it's cutting with endoscopic mucosal resection or endoscopic submucosal dissection, burning with radiofrequency ablation or hybrid APC, or freezing with spray cryotherapy or cryoballoon. For those patients who are not undergoing therapy, we monitor for signs of disease progression with endoscopy with biopsies. The Seattle protocol has long been utilized as a standard protocol to assess for occult disease or subtle disease in a Barrett segment. And this standard biopsy protocol includes forceps biopsies of all visible lesions, which, as we mentioned, were high risk or harboring neoplasia. And then random 4-quadrant biopsies every 1 to 2 centimeters throughout the segment, specifically every 1 centimeter if there's a history of dysplasia. For those patients with low-grade dysplasia, the annual cancer incidence is 0.5%, but dysplasia is challenging to diagnose. And it has, oftentimes patients with Barrett's esophagus have inflammation, which makes dysplasia even more challenging to diagnose by pathologists. Therefore, all cases of dysplasia should undergo review with an expert GI pathologist. Most patients with low-grade dysplasia, in fact, are downgraded upon expert review, and there is a subset of patients with low-grade that harbor a high risk of progression to cancer. Therefore, patients with confirmed low-grade have the option of close surveillance or endoscopic eradication therapy, and the rest of the patients we monitor closely with surveillance. Those patients with no evidence of dysplasia have a much smaller risk of progression to cancer, with an annual cancer incidence of 0.3% or less. Therefore, most of these patients may undergo surveillance every 3 to 5 years. Those that are deemed at high risk may be considered for closer surveillance or even endoscopic eradication therapy. But up until recently, we have not really had good tools to determine who is at high risk. Another challenge is the issue of pathologic diagnosis, which all of our management strategy is based. But dysplasia is challenging, again, to diagnose in the setting of inflammation. Indefinite for dysplasia is reported when there are atypical changes that are difficult to tell the difference between inflammation and dysplasia. And some of these patients may end up more like non-dysplastic patients, but others may progress to low-grade dysplasia. Indefinite for dysplasia is a temporary diagnosis. Our recommendation is to repeat the endoscopy with biopsies in 3 to 6 months to determine if there's dysplasia or not. If it is again present, we may have to have that patient undergo again another endoscopy with close surveillance. The clinical risk factors include gender, age, race, weight, family history. Endoscopic characters that we can look at include length of Barrett segment, presence of visible lesions, and histologic characters include the focality of the dysplasia, whether it's present at multiple levels, and whether it's persistent. The Seattle protocol has long been utilized as a standard protocol, but limitations to this include sampling error, lag time in the histologic diagnosis, and poor adherence. Unfortunately, poor adherence is associated with increased risk of missed neoplasia, and longer segments, which are more at increased risk for harboring neoplasia, are more associated with poor adherence. Thus, our standard protocol may be subject to a lot of variables and poor adherence, making it not so reliable. Some challenges with prediction of Barrett's esophagus progression include that we're looking for a needle in a haystack with a very low risk of progression among those patients with no dysplasia. There's a lot of inter-observer variability among those patients with dysplasia, and even among pathologists and among expert pathologists. We have a lot of patients with low-grade dysplasia who are overdiagnosed, but a small subset do carry a high risk of progression. And there are a lot of cases of missed high-grade dysplasia and cancer, with almost a quarter of patients who underwent an index endoscopy being diagnosed with high-grade dysplasia or cancer in a meta-analysis performed of over 800 patients. So what can we do? Well, we can offer better prediction by offering a better diagnosis and better detection. We can do that with a high-quality endoscopic examination, with adjunct techniques such as advanced endoscopic imaging, adjunct tissue sampling techniques, and endoscopic mucosal resection. And we can also use biomarkers for risk stratification. Many recommendations by numerous guidelines, best practices, and reviews offer us advice for how to perform a high quality endoscopic examination. We want to essentially perform the 5 L's, which are listed on this table. We want to first perform and measure, and we want to first identify and document the landmarks. Then we want to measure and document the length. We also want to look carefully with a good scope, proper inspection technique, and adequate time. And then we also want to identify, document, and target any visible lesions with tissue acquisition. And then we want to interrogate the rest of the Barrett segment at multiple levels with a standard Seattle protocol biopsies. We can consider the use of a distal attachment cap, chromoendoscopy, virtual chromoendoscopy, consideration of adjunctive tissue sampling techniques, and endoscopic mucosal resection when appropriate. Now, these things do a better job of detecting and diagnosing, but they don't really risk stratifying in the same way that biomarkers can. We have P53, which is probably the most investigated biomarker. IHC is the most widely used assay for P53 assessment. A meta-analysis performed by one of our former fellows demonstrated that P53 aberrancy carried an odds ratio for Barrett's to exhibit progression to neoplasia of 3.8 among 8 retrospective case control studies and a relative risk of 17 in 7 cohort studies. Although this assay has been incorporated in the British Society guidelines, it has a lot of variable issues with technique and interpretation and doesn't meet Dr. Souza's criteria for an ideal biomarker. As Rhonda detailed, we do now have a commercially available panel of biomarkers, which can utilize these biomarkers and morphologic features to determine a risk score and 5-year probability of progression and risk class with the TissueCypher assay. This allows us to risk stratify patients at a quantifiable level at or beyond or earlier than what we can obtain with expert pathologic review. I remembered my aha moment when I understood the value of TissueCypher when I was looking at the Davison et al. Paper. As we can see, the original diagnosis is shown in the left panel does not really stratify these patients well between low-grade dysplasia, indefinite for dysplasia, or non-dysplastic Barrett's. But an expert pathology review allows us a better positive predictive value of 21% and more risk stratification compared to the original diagnosis by a mix of expert and community pathologists. In examining how TissueCypher operates in these patients with an original diagnosis of non-dysplastic Barrett's, we can see in the right graph that the high risk determination as shown in red, can provide risk stratification with a positive predictive value of 31% among those non-dysplastic patients for risk of progression. And that behaves similarly to the stratification provided by expert pathology review for those patients who are deemed to have low-grade dysplasia. And this expert review called low-grade dysplasia is an actionable diagnosis. And here we have a quantifiable measure that can perform even better and perhaps earlier than that expert pathology review. TissueCypher was shown to show the management plans change in a study with pre and post assay management plans among 2 gastroenterologists in over half the cases. When I think about how I look at TissueCypher and how could risk stratification change my plan, well, we can look at several cases. So first of all, if we look at non-dysplastic Barrett's, the guidelines suggest that surveillance can be done in 3 to 5 years. But if I had more information, could I stratify that plan and individualize it more? If we look at those patients who have a high risk score, we may opt to shorten that surveillance interval to maybe even 1 year, and use our optimal high quality endoscopic examination technique, consider enhanced imaging, maybe even have a lower threshold to perform endoscopic mucosal resection, or in a subset of patients, even perform endoscopic eradication therapy. Whereas those low risk score patients may not need to have surveillance in 3 years, and maybe we can lengthen it out to 5 years and spare them the unnecessary burden and risk of endoscopy procedures among those patients who are less likely to benefit. In those patients with indefinite for dysplasia, rather than having a temporary diagnosis and just waiting, maybe we can make some more plans earlier. We can consider an early endoscopy among those high-risk patients with, again, those optimizations of a high-quality examination, enhanced imaging, low threshold for EMR, consideration of eradication therapy in the appropriate patient, whereas those low-risk patients may enjoy a longer interval prior to that next endoscopy. And those patients with low-grade dysplasia, again, we can consider a close interval or a endoscopic eradication treatment program for those patients who are high risk, but then consider surveillance more confidently for those patients who are low risk. So I present to you 2 patients of mine who had low-grade dysplasia. Case A was a 75-year-old male with a BMI of 25 and healthy, long segment Barrett's, and had low-grade dysplasia, which was confirmed. And he was referred because his doctor told him he needed ablation. Case B was a 75-year-old male, BMI is 35, had some cardiac issues, had a long segment of Barrett's esophagus with confirmed low-grade dysplasia, and was pretty much comfortable with the idea of just getting an endoscopy with biopsies when he came. So based on this information alone, we would think the first patient probably should just get endoscopic eradication therapy, and the second patient probably should just get surveillance. So going into a little bit more detail, the first case, 75 years old, had 6 centimeter segment of Barrett's with a hiatal hernia. Low-grade dysplasia was confirmed. A repeat endoscopy was performed, and low-grade dysplasia was again confirmed. And he was referred for ablation, but he was very wary of multiple endoscopies and ablation in general and all the risks associated with the procedure. So we went ahead and performed an endoscopy with a low threshold for endoscopic mucosal resection. And there were no visible lesions seen by white light endoscopy, but there were 2 flat mucosal irregularities noted by narrowband imaging. I performed endoscopic mucosal resection of both of those areas, as well as mapping biopsies of the rest of the segment. And there was no evidence of dysplasia on my endoscopy. So what would you do on case A? Referred for low-grade dysplasia, confirmed with ablation, but didn't find anything on this examination. If you have a moment now, please answer this polling question. What would you like to do for case A? Proceed with endoscopic eradication therapy. B, surveillance in a year. C, surveillance in 2 to 3 years. or D, it should be TissueCypher. So it looks like many, over half has wanted to do TissueCypher. So let's look and see what the TissueCypher results are, which was done. So the risk score was 3.2, which was deemed a low risk class with a risk of 5-year cancer progression to about 2%. So knowing now this results of TissueCypher, what would you like to do for case A? Proceed with endoscopic eradication therapy, surveillance in 1 year, surveillance in 3 to 5 years. And if you could just answer your polling question again, knowing the results of TissueCypher for this case. Okay, it looks like we are looking at surveillance, whether it's 1 year or 3 to 5 years, it's a little bit of a mix. So I spoke with the patient, we decided to repeat in 1 year, but certainly felt more comfortable with surveillance knowing these results. And he felt comfortable knowing if dysplasia returned, he might consider endoscopic eradication, but he was quite happy if there was no evidence of further dysplasia, then to move towards a lengthening of a surveillance program for him. And he was quite satisfied with his care and happy that he did not have to undergo ablation at that point. So looking at the second case, case B, this is a 75-year-old male with a long history of Barrett's esophagus, had a previous diagnosis of low-grade dysplasia and underwent RFA with some complications and discontinued eradication therapy, and also had required multiple cardiac procedures and was on anticoagulation for some time. He was willing to undergo treatment, but if he didn't need it, he didn't want it. Fortunately, his cardiologist was willing to work with us. There was a lot of collaborative decision-making going on with the cardiologist and what we needed to do from a GI standpoint. We decided to go ahead and perform an endoscopy, and he had a C15 M16 segment with focal low grade by biopsy. We decided to go ahead and proceed with a repeat endoscopy and had a low threshold for endoscopic mucosa resection. Anticoagulation was held for the procedure, and EMR ×3 was performed. Random biopsies were also performed, and he had multifocal low-grade dysplasia. So with that, what would you like to do for case B? A, endoscopic eradication therapy now. B, wait until cardiac issues were more stable and proceed with endoscopic eradication therapy later. C, surveillance in 3 to 5 years. Or D, TissueCypher. So if the polling started, go ahead and answer what you'd like to do. Okay, looks like over half would like to proceed with TissueCypher, which is what I did. And we sent the results for TissueCypher. And here we had a risk score of 5.3. It was on the cusp of intermediate with a 5-year progression rate of 5%. So knowing the TissueCypher results, what would you like to do for case B? Endoscopic eradication therapy now. Wait until cardiac issues were more stable and then proceed with endoscopic eradication therapy. And then C, surveillance in 3 to 5 years. And again, this is our polling that you can answer your question. Okay, a little bit of a split, but I went with the majority here, which was wait until the cardiac issues were more stable and then proceed with endoscopic eradication therapy. This was, I think, a nice compromise because we knew that we could proceed with endoscopic eradication therapy, but there wasn't necessarily the urgency to do it right away. And especially with a 16-centimeter segment, it wasn't going to happen quickly. So in fact, we're still undergoing therapy. But these cases illustrate some, not the extremes of what you do with a perfectly, healthy patient with low grade, with a high risk score, or the complete opposite, but some of these intermediate decision-making options that we explored, because we had these two patients with low-grade dysplasia, both the same age. One was a little healthier than the others. But whereas one, I might have thought to proceed with surveillance, I think the TissueCypher score allowed me to really think about that patient and then consider endoscopic eradication therapy. Whereas the other, who had an more intermediate risk in the setting of persistent dysplasia, we were able to identify there was a risk, but also know there wasn't necessarily an urgency, and then address the cardiac issues first. In any of these, it's important to perform a lot of patient counseling and really go over the treatment commitment to the patient. No, it's not a one and done procedure. Talk about the risks, talk about the cancer risks, and put it all into perspective. The example that I always use for patients is, because they always look at me funny whenever I say per patient per year, about 5 times. In fact, my eyes start to get glazed over. But they hear Barrett's and they hear esophageal cancer, and they think no matter what, they're going to have esophageal cancer, and they're on a destination, no matter what it is that I've told them, that they're going to get esophageal cancer. And so I asked them to imagine that they are in a train station, and there are multiple trains going to multiple different locations. And in one of those trains, one of those destinations is esophageal cancer. If they have high-grade dysplasia, they are on that train heading to esophageal cancer. And I don't know if it's a next stop or 5 stops from now, but they are on that train to go to esophageal cancer. And I'm going to do whatever it takes to get them off that train. I'm going to cut it, burn it, or freeze it to get them off that train, and we'll accept the risks that come with that. For the low-grade dysplasia, I tell them, well, we need to find out what direction you're heading. We need to determine, where they're going. Are they going to get on a train? When are they going to get on a train? And is it even going in the direction of esophageal cancer? And I tell them, well, it's like you're in the ticket line, and we just have to wait until we see what you get. And we might need more information. It might mean another endoscopy. It might mean an endoscopic mucosal resection, or it might be a TissueCypher assay. And we talk about it with the patient and determine what they're comfortable with to get more information to figure out if they have to do whatever it takes to get off that train. So pearls for clinical practice: there is a need for additional risk stratification in Barrett's esophagus among patients with non-dysplastic Barrett's, indefinite for dysplasia, or low-grade dysplasia. A small subset of these patients may benefit from close surveillance or even endoscopic eradication therapy, whereas the vast majority of the rest may be spared aggressive management plans. Patient factors, endoscopic features, histology, biomarkers, and patient perspectives are all needed to better individualize and manage these patients. TissueCypher enables risk stratification beyond what is provided by conventional histology, even by expert pathologists, and even perhaps at earlier stages. And shared decision-making and patient education and counseling are critical in caring for patients with Barrett's esophagus. Thank you.
Thank you, guys. That was fantastic talks by our speakers. Apologize, I'm struggling with my camera, but I do want to dive into some questions for you guys. And the first thing, Vani, I wanted to maybe ask you, often the clinical scenario, one of the that you pointed out, is where we see a patient, we take biopsies, we get low-grade dysplasia, or we get some dysplasia. We send it out to a quote-unquote expert pathologist. We could talk about how expert they are, and they downgrade, or whatever they do, they change the diagnosis. Let's say they downgrade it to no dysplasia. Is there a role here? Because we've all commented and we've all heard you guys talk about, and the literature supports the lack of agreement between pathologists of any grade, sorry, no pun intended, for diagnosing dysplasia. So is there a role here for discrepant diagnosis for something like this to help us out?
I think this is an excellent role for something like these discrepant situations where you might have low-grade dysplasia in one setting, and then you either have something downgraded, but there's still obviously concern, or you have different pathology reviews, and there is a variability even among expert pathologists. I think it's important not to jump to eradication therapy or ablation just because someone had heard the word low-grade dysplasia, but there's a lot of fear that comes when you talk about a precancerous lesion that you might be harboring. And sometimes it's not comforting enough just to say, oh, well, the second guy said there was none. And TissueCypher really allows us a more robust way of looking at the tissue with a quantifiable approach with multiple biomarkers and features that I think can really put patients a little bit more at ease.
That's great. Rhonda, can you comment a little bit on sort of the spatial aspects of TissueCypher? In other words, if we're is there value at doing this, at different levels within a dysplastic segment or in a longer segment, Barrett's?
Yeah, there's a paper that that's been published looking at spatial location, and that the ability of the assay for detection is better if you look at more than one level. So you can increase the sensitivity and specificity by looking at more than one level.
Excellent. Vani, the question came up about a little bit, there's a lot of new adjunctive tools for us clinically. What about the role of better sampling with something like Watts? Is there also an opportunity to use the better sampling with TissueCypher?
So, I think one of the ways that we can use TissueCypher that's important to recognize is that you can use TissueCypher on previously obtained tissue. And so it might be that there is already an endoscopy that was already performed, and that you already have taken biopsies, and obviously the more levels, or the more sampling, the better. But in terms of it can be done on archival specimens. When you have additional adjunctive tissue sampling techniques, such as wide area transepithelial sampling, you can do that as a way to gather more tissue, but that will be something you're doing at an upcoming endoscopy, or you decide to do at the time of the endoscopy. The Watts brush allows us to detect dysplasia using, and also other features like cryptdysplasia, using the cell collection and also a computer-aided algorithm to help pathologists determine where to look to help confirm the diagnosis of dysplasia. I'd love to see different variations and permutations of more tissue sampling for TissueCypher. Currently, there's not necessarily a combination of those two methodologies. I think they both have advantages and disadvantages, but I think they're complementary.
Agree. I think that's a great point you made. One of the things, you spend some time talking about low-grade dysplasia. I want to crack a little bit of the nut of non-dysplastic Barrett's, but in a different way than you might perceive. That is, when we have this giant pool of non-dysplastic patients, or you have a very concerned patient, is there potential to use this tool as a negative predictive value in somebody without dysplasia to stop surveillance?
So I think that it has excellent negative predictive value among those patients with non-dysplastic Barrett's, and really can be easily used for lengthening surveillance and in the appropriate patient stopping surveillance, especially if the risks of endoscopy start to outweigh the benefits. And I think that's where individualized decision-making comes into play. The lengthening of surveillance and the calming of patients' fears is probably something that we could do a little bit more time talking about. So I value that question. Patients really are driven by sometimes more anxiety to make some decisions than actual risk of progression numbers or probability. Sometimes patients who have been diagnosed with Barrett's think their likelihood of dying of esophageal cancer is greater than having heart disease or diabetes, which is not usually true. But it is that anxiety that is driving them. And so I think we can also teach our patients, but we can also teach ourselves not to over survey patients with Barrett's esophagus and work on ways of lengthening or decreasing surveillance using proper risk stratification like TissueCypher. Rhonda, do you have anything to add on?
No, that sounds great.
So Rhonda, I'll come back to you. It's not, it's fairly common that patients now are, looking for a magic bullet. They're getting their, cancer blood tests across the board and going to medical geneticists. When you, as gastroenterologists in this crowd, and people start talking to patients about biomarkers in general, what are some of the key points that, when we order these type of tests? I think we just order tests sometimes. We don't think about the impact of it. And not that this is, looking for genetic, predisposition necessarily, but is there anything we should be telling patients about biomarkers to help them, if nothing else, better understand what we're trying to accomplish?
Yeah, that's a great question. They're not a magic bullet. They're going to give you maybe a better predictive power than just looking at the histology. And so a better predictive power than just saying non-dysplastic Barrett's, I think. I think what Vani talked about in her discussion was more of the individualized patient counseling about the pros and cons of what the biomarker would tell you to do, whether it's going to be an invasive therapy, whether it's going to be more surveillance, and sort of the whole package that it comes with.
And if I could add and put a plug in for one additional thing. So that whole explanation of risk and also even that train analogy and how I explain it to patients, we worked with Cernostics to actually create a patient video. That's a short patient education video in layperson's terms that you got to hear basically the whole spiel, only it's much shorter for the patients, that is available. And I believe that will be shared with all the attendees tonight as a link for you to have available as a resource to talk to your patients with or provide them that resource. And there's also a patient education manual that Cernostics can provide as well to sort of help talk through some of these more complex and abstract thoughts about risk stratification and biomarkers with your patient.
Excellent. Vani, a few people have asked questions around the reimbursement landscape here, and maybe you could comment briefly on that.
Sure, I'll try and take a crack at it. TissueCypher is being covered by Medicare, and then also so far there's been pretty good coverage by commercial payers. However, different insurance companies do have co-pays that sometimes patients might be responsible for. But so far we've been seeing a pretty good reimbursement across TissueCypher. So that is probably the extent. If anyone needs to add any more information, I'll stop there.
Thank you, that's helpful. One other thing that's come up, which I think is important, is just the logistics of TissueCypher. Who sends this out? Is this your responsibility in the lab? Is it pathology? Do you need to have how does that work?
So basically, there's a pretty easy one-page form that you as the physician fill out, and it is something that you will provide the information to the pathologist, and you include, the specimen, what day the specimen came from, and give them enough information to be able to identify the blocks, and then you pick which blocks you want based on the pathology report, but then the pathology department then sends that out, the slides as requested by Cernostics, and Cernostics will work with the pathology department to help get the information they need. But as a physician, you basically fill out a form.
And Vani, I'll jump into, you can send, as my understanding is, you can send as many blocks, like slices from as many blocks as you would like for your patient, and it all encompasses just one charge, so they can check multiple levels to give you that spatial additional information.
And then, Vani, the last sort of selection question I'll ask you is that's come up. When we talk about our patients without dysplasia, there often is a situation where somebody sees us who's young, some of those, previously clinical risk factors, long segment, younger people, family history, Barrett's clusters, esophageal cancer. Is there any of those situations where you utilize this test, or it might be utilized in that small subset of patients?
I think there is a role for that. And like I said, I think it, depending on how many risk factors there are, you might consider it, as one piece of information among multiple pieces of information. I think it's really that whole package. But up until now, I have not seen anything that really makes me want to ablate a non-dysplastic patient until I've seen the kind of information that TissueCypher provides, knowing that it can provide the same amount of risk prediction that I am thinking about for a patient with low-grade dysplasia and a patient with non-dysplastic is valuable to me. So I think that, this would be the kind of information that's enough for me to make that decision. Whereas I felt like all the other risk factors, like you mentioned, long segment patient, Barrett's, young patient, family history, none of those were enough for me personally to make that decision. But what I do offer those patients, or any patient, is a high quality endoscopic examination and really a careful look and assessment. And I think that is probably another important point, but this would be, these kinds of assays that we're getting here is enough, I think, to really be able to start those discussions in my mind.
Excellent. Rhonda, one more question. Is there any utility for clinical use of one-off, in quotes, tissue biomarkers like P16, KRAS, aneuploidy, et cetera?
Not based on my reading, I wouldn't think so, because they've not been reproduced. Those are those one-hit wonders. Now, the only one that has shown reproducibility is the P53 immunohistochemistry. There's been a bunch of studies, and Vani was talking about our recent meta-analysis looking at those studies. The problem with that is it's going to depend on your pathologist, the staining, their interpretation, and there's no guidelines for what's considered abnormal P53 staining for overexpression or loss of expression. So you really are left with a lot of subjectivity in the calling of that. So I think that's sort of the big issue with using the P53 IHC.
Those are great. I think we've hit all the questions. I know we're getting close to the hour here. Thank you all and have a great night.
Thank you.
Bye. Good night. Thank you. Good night, everyone.